Greetings, everyone. Welcome to the second webinar of the series 988, It's Not Just a Number, hosted by the National Academies of Sciences, Engineering, and Medicine, its forum on mental health and substance use disorders. I welcome our virtual audience today and those of you who are viewing a recorded webcast. Excuse me. I'm Howard Goldman, professor of psychiatry at the University of Maryland School of Medicine. And I'm also the co-chair with Maggie Alegria of the Forum on Mental Health and Substance Use Disorders. And we welcome you today. During the first webinar in this two-part series, we learned that you can now access a national suicide prevention and mental health crisis lifeline by calling or texting 988. Speakers at the first webinar discussed funding opportunities used to promote implementation of the crisis service and the 988 call line. And they also focused on opportunities used to promote implementation and other sustainability challenges. This includes focus on state laws, Medicare and Medicaid policy, and private insurance. We heard about the current care continuum after someone dials 988 and the patient experience with the lifeline. There was a focus on resources and cultural competency. We discussed the need for data, for privacy, and overcoming stigma and legal barriers for promoting human rights. Now, if you were unable to tune into that first webinar, I highly encourage you to view the recording, which will be free to download on the event page in about 7 to 10 days. Today's program will feature state and local representatives discussing their best practices and challenges while implementing 988, as well as the Crisis Lifeline, of course. We're starting with a panel discussion that will be moderated by Stephanie Barrios Hepburn, and it includes Alexandria Robinson Jones from Virginia, Tim Marshall from Connecticut, and Jennifer Hallman from LA County. Following the panel discussion, we'll hear from two directors of mental health programs in two states, from Commissioner Slatton Hodges of Oklahoma and Ann Sullivan from New York State. Now, I promised folks at the National Association of State Mental Health Program Directors Research Institute that at this point I would mention that they've just released 10 new reports on state activities related to crisis services in 988. And those are viewable on the NASHBID Research Institute website. Now at 2 o'clock, we'll be answering your questions live, moderated by Dr. Bob Heinsohn from NIMH and Maggie Alegria. Then we'll come back on just near the end for a few closing remarks at the bottom of the hour. Full bios for our presenters are posted on the event page, and please join the discussion throughout the webinar by submitting questions into the question and answer box, and we'll try to get to as many questions as possible. Now over to Stephanie Hepburn for the beginning of our first discussion section.
Hi, my name is Stephanie Hepburn, and I'm the Chief Content Officer at RI International and the Editor-in-Chief of Crisis Talk at talk.crisisnow.com. Over the past 4 years, I've followed and written about what is now 988, speaking to leaders throughout the U.S. on next steps in 988 implementation. What has been and continues to be lacking is sufficient connectivity between 911 and 988 to ensure the diversion of behavioral health calls from 911, as well as interconnection within behavioral health systems. I've invited the following guests to discuss diversion and crisis system redesign. I'll have the panelists introduce themselves and their program. Let's start with Alexandria.
My name is Alexandria Robinson Jones, and I am the Marcus Alert Program Coordinator in the state of Virginia. In Virginia, we have been working over the past 2 years on our Marcus Alert system, and I will give a brief overview of exactly what the Marcus Alert system is, and then we can get further details as we move through the panel discussion today. Back in 2021, we had an article written for Crisis Now or Crisis Talk about our Senate Bill 1302, which established our Crisis Call Center Fund. So we were the first state to pass 988 service fee legislation, which was a tax that is funding 988 for the 2 regional crisis call centers in our state that are supporting the new 988 number. And we have PRS Crisis Link and Frontier Health in our state that are supporting that effort. In 2020, we had House Bill 5043 that passed, which addressed the mental health crisis system, and it required the Department of Behavioral Health and Developmental Services, the agency that I work for, to collaborate with the Department of Criminal Justice Services to develop what is called a Marcus Alert system in our state. A Marcus Alert system is made up of 3 protocols. So it's also a phased statewide approach. And when I say a phased statewide approach for these 3 protocols, it means that we started with 5 pilot sites, and those were localities across the state, 1 in each of our regions, so they span across the state. And each year, 5 more sites will implement until we have the entire state compliant with Marcus Alert by 2028. The 3 protocols that are required is 911 diversion to 988, to have law enforcement provide backup or emergency backup to mobile crisis teams when required, and also to develop a specialized response using best practices for law enforcement participation in the behavioral health crisis continuum. Another piece of Marcus Alert that's not highlighted as one of the 3 protocols in the legislation, but is a requirement, is phased in 24/7 community coverage of behavioral health teams to respond to behavioral health crises. And I think that's a good overview to stop on that program. So thank you, Stephanie, for introducing me.
Thank you, Alexandria. Tim, can you talk about yourself, introduce yourself, and also talk about the programs in Connecticut, particularly regarding youth?
Sure. Good afternoon, everybody. My name is Tim Marshall, and I'm representing Connecticut here. I'm actually currently working for the Innovations Institute, which as a senior advisor, formerly that was at the University of Maryland, but recently transitioned to the University of Connecticut. I also have retired recently from the Connecticut Department of Children and Families, but I'm back there on temporary assignment, helping to transition to Dr. Frank Gregory, who's replaced me. While there, I had responsibility of a large part of the children's community mental health system that includes the Children's Crisis Service Array, mobile crisis or our mobile response system, the crisis array, and a lot of the other parts of the system. I was also involved in overseeing the statewide suicide advisory coalition, the prevention board. I was also the department's representation on the 988 transition, both during the planning and implementation of that. I'm here mostly specifically to represent children and to be clear that children are not small kids, and not small adults, and they need to be intentionally thought about. And in particular, our mobile crisis response system in Connecticut. In Connecticut, we built that system to be very, very responsive. We really wanted them to be able to allow the parents or all callers that whatever the issue they were calling about was treated as the crisis. So we refer to it as the crisis is defined by the caller, or we purchased a just go mentality, if you will. So we purchased face-to-face assessment. We believe that the mobile response system in Connecticut is the backbone of the entire crisis service system. Connecticut has a ability to stay involved for up to 45 days for that critical linkage to long-term, more appropriate care. So we built the system to be very responsive to parents and callers, other caregivers, custodial caregivers like schools. And we think that face-to-face assessment is really important. So we set a benchmark of being face-to-face within 45 minutes. National average is often 60 minutes. And we receive over 20,000 calls annually. We have an average face-to-face rate in 30 minutes. So we are meeting that benchmark over 90% of the time. We do want to be also very consistent and have high quality. So The consistency we play out through two vehicles. One is a statewide contact center, both the call center and text and chat. And we also use a performance improvement center, which helps us with routine and consistent quality and workforce development across the entire system. So thank you for having me, and thank you for inviting me.
Thank you, Tim. Jennifer, can you share your role and also what's happening in Los Angeles City and County?
Hello, good. It's morning here in LA. So good morning, everyone. Jennifer Hallman. I am the relatively new alternative crisis response manager within LA County for the Los Angeles County Department of Mental Health. And my team now is responsible for coordinating the entire mental health crisis continuum of care within LA County. LA County has nearly 10 million people, over 4,000 square miles. So it's a large area, many cities, many police departments. And so what we have been trying to do is really coordinate the crisis continuum across all of those different agencies and organizations. Our goal or our vision is that individuals experiencing a mental health crisis in LA County are treated quickly, effectively, and with empathy at the least restrictive level of care to meet their short and long-term needs in the mental health system so that they can remain in the community. And so what that means is we've had to redesign or relook at our entire crisis continuum, given that many people, when they're in crisis, their default was to go to 911. So we want to reimagine that, redesign it so that the entry point becomes 988. And then we ensure that we have mental health field response teams available 24/7 throughout the county to respond. And then we have receiving facilities to address the needs of that individual in crisis if needed. And then we've really added a fourth pillar to that of having some place to treat the mental illness or the mental health condition so that we don't have just that revolving door of crises. And then we can get them in for treatment, whether that involves outreach and engagement or simply scheduling an appointment quickly.
Thank you so much. Thanks, Jennifer. So my first question for the panel is that for many programs, there's a tipping point or an event that's the impetus for program development, redesign, or expansion. I'll start with Alexandria. If you could talk about what pushed Virginia to develop a statewide 911 call matrix.
Sure. So in the summer of 2020, across the nation, we saw a social justice movement taking place. And in that November, our then governor signed what was called, or what's been named, the Marcus David Peters Act into place. So Marcus David Peters was a young Black high school biology teacher who experienced a very public mental health crisis. It resulted in him experiencing a car accident, and he was responded to by Richmond City Police here in Virginia, and it resulted in his death in a police shooting. And that was in 2018. So since then, there was community activism, primarily led by his sister, asking for change, demanding change in our behavioral health crisis system, as well as in the way that law enforcement responds to those individuals who are experiencing behavioral health crises as well. And from there, we saw the signing of this act, which required Virginia to not only develop this Marcus alert system, which really makes us unique in the nation, having this statewide 911 diversion mandate, but it also required us to develop a crisis continuum, including those elements of the Crisis Now model.
Tim, do you want to answer that question as well? It's really about what's the tipping point, and with every state and community, there's some similarities, but there's often some nuances and differences. Could you talk about what happened in Connecticut, what you were seeing?
Yeah, so over 15 years ago, 16 years ago, when I first took over and was looking at the mobile crisis system and I took over that, one of the things I learned right away from families, they said to me frequently, we're not calling them as much anymore. We're trying to avoid calling them because when we call them, they don't come. And what they were very frustrated with was that when they called, their crisis described was, quote, screened out. So they got a telephonic response only. And we build it as a mobile response system. So in some parts of our state, our response rate was, 25 to 30%. Our statewide response, face-to-face response, was 50%. So it was the toss of a coin about if you called in crisis and whether somebody actually came out. So when I took over, I realized we had a major problem because we wanted people to use the service. So we set about, it took us multiple years. Our system is now 12 years old. So it's about 2010 that we had the beginning of the new system. But that's when we really decided that we were not going to purchase a screening process. We were going to purchase a face-to-face assessment. And we set the statewide benchmark at 90%, 100% response to every caller. But we expected that the response, the face-to-face response rate would be 90% of the time. That allowed for 10% of the time parent choice to say, I just only want to talk on the phone. And that has held up for these multiple years. But that really was the tipping point when parents and youth were really frustrated with the lack of responsiveness of what our system was.
Thank you, Tim. Jennifer, what about in Los Angeles County? What was the tipping point?
Yeah, so I would say, like Alexandria, the tipping point was really the social unrest. In June, our board of supervisors motioned for us to really look at the entire continuum, look at the situations where, unfortunately with law enforcement, those situations can escalate and turn fatal. And so really looking at why we're having to go to law enforcement when maybe they aren't needed. And so as we started doing that, we really looked at, there's people being served by law enforcement when it's not needed. There's people being served in the ERs, in inpatient facilities when that's not the level of care that they need. And there's even situations in which our mobile response teams are going out on calls that really don't warrant that level of crisis response, but people just didn't have anywhere else to go. And so we've really, with that social unrest and then really starting to dig into our system and where people are being seen, we've seen that we really need to have systems in place that we can move individuals to the right level of care to best meet their needs. But that means we need to have capacity at that level to treat them.
And I guess also coordination, right? So capacity.
Huge, because if you don't have that coordination, you don't have those screening tools, you don't have the triage system, then you're never going to be able to move individuals either to a higher level or lower level, or direct them to the right level. And then you end up with people just moving around the system to places where they really don't need to be.
Thank you, Jennifer. So my second question is that many behavioral health calls that come into 911 are from third-party callers. And that means that they're reporting on what another person's experiencing, and that comes with inherent pitfalls, obviously. And it's also affected and influenced by the caller's own biases and issues. And so when we talk about that, Tim, if you could share when it comes to youth, why does it matter if it's a third party calling when you're responding to youth behavioral health crises?
Sure. And I believe the callers calling on behalf of either an adult or a child, I believe it's much higher percentage of callers are calling on behalf of a child than it is adult. More adults call from themselves than children. What we learned is that the third party, whether it's often the parent themselves or kind of like a custodial parent, caregiver, like a school personnel, is that they're not the one in crisis. And so what we have found is that sometimes parents themselves are in a crisis. Sometimes they're aware of that. Sometimes they're in a parallel crisis that they may or may not be aware of. And also if the callers from schools, and by the way, those are the two primary callers, schools call more frequently, slightly more than parents do in Connecticut, and it's the largest percentage of our callers. That schools have the best interest of all students, not just the child that's in crisis. And so sometimes there may be issues that are being shared about the child or the student in crisis as a result of what other students may or may not be experiencing. So you're not getting necessarily the full assessment of what the child is experiencing who is in the crisis. Additionally, developmentally, kids are different than adults, and not all adults tune into that. And even caregivers and parents, sometimes we lose sight of that. Kids usually don't sit across from us and tell us exactly what's going on for them. And sometimes it's kind of figuring that out. And lastly, I would say that it really becomes really important to get a sense of the environment that the child's in when they're experiencing their crisis. So again, that face-to-face is so important. So we really work hard at the default response being a face-to-face assessment, taking what the parent has to say, taking what the caregiver, school staff, and others have to say. But it also allows us, when it is the parent and going to the home in particular, we're allowed to see, is there other siblings in crisis? And we're all also able to assess better the needs of the parent and be able to do a family intervention as a result of the crisis. So for kids, I think it's really intentional for us.
Thank you, Tim. Alexandria, could you answer that same question? As you scaffolded this, what were the thoughts and what already were the challenges presented from third parties that were calling into 911? And now as 988 becomes more and more known, the hope is that people are going to know about 988 the same that they know about 911. So there might be an increase in those numbers of callers who are third parties. How are you navigating that?
Sure. So third-party calls are a concern. Primarily, I hear about this as more of a concern for our 911 partners when trying to figure out what's the best solution. When they think about transferring calls to 988, they think about an individual getting the supports over the phone for their own health, not necessarily for someone else. And so where we are currently in Virginia with our pilot sites, when it comes to third-party calls, if the 911 operator is questioning whether it's an appropriate transfer or not, typically they'll go ahead and dispatch. If it comes to if they aren't sure it's a appropriate 988 transfer, they'll dispatch law enforcement. Typically, what's helpful in that situation is that under Marcus Alert, it really requires only specialized teams to respond, specialized law enforcement teams to respond to those identified Marcus Alert type calls or behavioral health type calls. So once a law enforcement officer is being dispatched, it's preferential dispatch of a CIT trained, mental health first aid trained officer going to that scene. And so that's something that we're ongoing kind of addressing, is what to do with those third party calls as 988 becomes more familiar, and as our 911 call takers and dispatchers become more familiar with 988 and the resources. We hope that this is something that culturally will change. But currently that's how those are primarily being handled at this point for those third party calls.
And Jennifer, could you answer the question as well? When it comes to third-party callers, how is that a consideration, both again to 911 and potentially and likely the more that 988 is known, you're going to get an increase in those third-party callers as well. How has that been built into the crisis redesign?
Yeah, so I think it's timing is really, I think the biggest consideration here, is because, we really want to start marketing 988 as being the go-to place if there's a mental health crisis. The challenge with that is if it's a third-party caller, more often than not, as Tim mentioned, you're going to need to dispatch a team. And so if 988 can't dispatch teams, right, then you're directing people to a location that isn't going to meet their needs. And so currently, pre-988 implementation, and even to this day, our local 988 center, less than 10% of their calls are third-party callers, versus our own DMH helpline, which has historically taken crisis calls. It was the reverse. It was 90% of our crisis calls were third-party callers. So if we started all of a sudden directing all of those third-party callers to 988, but 988 isn't going to be able to dispatch, then we've just put people into a circle. So then we had to start looking at, okay, can we make that connection between 988 and our access center, our DMH helpline that can dispatch teams? Can we at least make that connection? So it was really it all becomes, I think, timing, because all of these pieces impact other parts of the system. And so you can't just look at, just simple like, oh, let's just focus in on 988, because as much as we'd like them to be able to resolve the call over the phone, they are going to need those alternative methods. And we don't want them to have to rely on 911. So then we need to look at how do these things piece together. Same thing with 911 to 988, right? Is you're just piecing all these things together and then just thinking, what's our messaging to the community of where to call? And that, I think, has been one of those things that we're really thinking through, the timing of everything, the messaging of everything, and how can we piece everything together.
So Jennifer, that leads perfectly into my third question, which is, as communities build out their 988 crisis systems, ensuring people not only have a place to call, but also services that will go to them in places within the community where they can go, they have to address gaps in services and gaps in communication. In many places, there's insufficient linkages between programs within behavioral health. And I know in Los Angeles County, there were some challenges in terms of the connection between 988 and mobile crisis. Can you talk a little bit about that and how in your system redesign, you really not only focus, again, like you mentioned, about that connection between 911 and 988, but also within the behavioral health crisis system and system generally, having those interconnections between them?
Yeah, and it's so much about knowing, right? You need the right information at the right time so you can connect people to those other systems as they need them. And so, LA County is large. We do have over, depending on the moment, we have upwards of over 30 mental health teams in operation. That does not include our co-response teams with law enforcement. This is just pure mental health teams. And they are dispatched, they are dispatched within their each area. So only that area knows the availability of the teams, right? And so we really, if 988 was going to be able to transfer a call over to us for dispatch or to reach a mobile response team, they need to know some assurance of team availability. So they're not just cold transferring a call for somebody who's really in crisis. You don't want to just let it go, not knowing if something's going to be available. So to that end, we set up a priority line to transfer the calls over to us so that they can get answered quickly. They're not waiting in line with other calls coming into us. And then we're also building out a dispatch board. And that dispatch board will identify all of the crisis calls awaiting dispatch or that have teams sent out on the calls. They are also prioritize those calls into high, medium, and low. So you have an idea of, this area, they have 3 high priority calls awaiting dispatch. This area, they have 2 medium, etc. And so we are going live with that board 24/7. It's a huge step for us. We're going live in the middle of February. And then our next step after that will be to put availability of teams into it. So the first step is just knowing what are the calls awaiting dispatch. And then the second step will be knowing availability. We believe that is the key. Having that in operation is going to be the key to 988 being able to transfer those calls over to us for dispatch. Because again, when somebody's in crisis, you can't make multiple phone calls to find out team availability. You need one central place so you can quickly get an idea. Yeah, we could have a team available now or shortly within the next 30 minutes or so.
And really briefly, Jennifer, can you tell me who will have access to that platform? And then what are your hopes in terms of who might have access to it in the future?
Yeah, so all of our teams our field response teams will have access to it, so they can update their status, they can enter dispositions, kind of the status of the call. Our call center, our DMH helpline will have access to it. And then our plan will be that eventually 988 agents here in LA County, operated by Dee Dee Hirsch, they will also have access to that board so that they can look and see kind of what the status of things are.
Thank you. So the next question is, not all communities have the same starting point. Some have fairly robust crisis continuums, others are just beginning to build out their services. So I'm going to pass this and start this with Alexandria. I know that this is something that you've had to really deal with in Virginia. If you could talk about, when it comes to a statewide protocol, how did you have to account for localities that haven't yet established or have understaffed mobile crisis services, similarly to what Jennifer was speaking about, but here you have these statewide protocols. How do you deal with that?
Sure. So it definitely is a challenge, and it still exists as a challenge for localities and communities as they conceptualize exactly what Marcus Alert is going to mean for their community. However, when developing the statewide plan, this was a legislative requirement to create a stakeholder group made up of about 35. It consisted of 35 members, but made up of various backgrounds, including law enforcement and behavioral health, emergency management, and substance use disorder, disability justice, and others. We wanted to make sure that we had a statewide framework that was developed that would be able to be adaptable to those various communities. In Virginia, like most states, we have very rural, we have your urban, then largely suburban areas. We have a large military presence here in Virginia in our Tidewater area. We also border DC, so in our Northern Virginia, a lot of people say it's like a different state there, but it's a very transient population, as well as large universities that attract a lot of students. So the state just looks very different. And so having a statewide framework, that was the essential part, was making sure it was adaptable for communities depending on if they had mobile crisis teams or co-response teams that were embedded locally, or if they were really starting from scratch, like you said. And so our statewide framework, really it relies on regional assets that are being developed when it comes to those behavioral health teams. So being funded through statewide initiatives is our regional mobile crisis teams. Now, some localities, in addition to that, will have a mobile crisis team that just serves their specific city, or they might have one that serves, maybe their jurisdiction and another county next to them. They might have a co-response team that consists of local law enforcement along with behavioral health folks riding along. It can look really different. Most of those are going to be locally funded initiatives. So it's not consistent across the state where those exist. But the way that we've developed Marcus Alert is that for those response options that are allowed, that they can use those, they can either rely just on those regional assets that are being developed. So it doesn't put the responsibility on the locality to fund and staff a new team. Instead, it's regional. Or they can incorporate those local assets also and have them responding to calls as well to achieve that community coverage. So it's difficult right now in today's workforce, right? I think across the nation, experiencing this behavioral health workforce shortage is difficult staffing those regional teams. And so we really do rely on localities to kind of work together, and they've been really innovative in how they're recruiting, also making sure that we're having a robust staffing of those teams. So not just relying on licensed professionals to staff those teams, but also making sure that we're including individuals with lived experience, or in Virginia, it's peer recovery specialists or certified peer recovery specialists to respond in those roles as well. So it's a continual process of making sure that we have those teams staffed and are able to equip those regions with those mobile crisis teams. But it definitely has been a challenge of making sure that a Marcus Alert system, it doesn't look too different across the state, because we do eventually want a Virginian who is in one county to be able to go to the next and still receive adequate care. However, just because of the nature of the state, it does look a little bit different from locality to locality.
Thank you, Alexandria. Tim, I know Connecticut's small, but still you have regions. Can you talk about those similar struggles in Connecticut?
Yeah, so probably the biggest answer to this we addressed 12 years ago, and that was one, we built into the model itself. We have the first phase of that, which is to stabilize the acute crisis at the time, but we do have this 45-day linkage and follow-up that allows the mobile crisis clinicians to maintain the opening of the episode of care. So once that acute phase is stabilized, if there's a referral and a linkage to another next level of service quickly, then they close that episode of care. And that does happen the majority of the time. Connecticut being small, and we do have a very robust system, but we do have this challenge still in our state. And that up to 45 days, the other piece we just recently added in our state plan amendment, we're submitting, I believe it might have already gone in, but I believe it's supposed to go in before the end of January if it hasn't, is to add parent peer support to be able to be reimbursed for that stabilization component. So if we need to keep the family situation open while we're waiting for that linkage to the next level of care, we can do that. Additionally, we're building out 2 or 3 other levels of care. One is the 23-hour crisis stabilization that we're going live in March, so it's not going to be too much longer. And then the crisis stabilization, which is crisis residential for up to potentially 14 days. We're building 4 of those units also, as well as those 4 UCCs. So we'll be adding to the array also to help move those families through quickly.
Thank you, Tim. So the next question, actually, we'll start with you, Tim, is in many schools, kids experience mental health or substance use challenges, and they often, they actually often face punishment instead of care in schools. And we've talked about this before, but it's kind of the default response. If you could talk a little bit about that and the disparity with Black and Hispanic children who are more likely to be disciplined. And I know that's something you have been very cognizant of when it comes to Connecticut's Youth Mobile Crisis Program. How has it helped decriminalize behavioral health and divert young people from a law enforcement response?
Yeah, so a couple things. Number one, we find that when you're very responsive with your mobile system, the total number of families we serve, if you look at both the breakdown of access, who's accessing, and what the outcomes are, we find that our mobile response system is the most diverse and has the least disparities in it. And we respond particularly to children of color and different ethnicities and backgrounds and different linguistic needs, much more higher percentages than what they are in the general population. And we think that's very necessary because very often they're overrepresented in both the child welfare and juvenile justice. So if you're underrepresented in the behavioral health system, you're giving a double disparity. Right. So we think that overrepresentation in mobile crisis is really, really helpful. The second thing we do in our routine community outreach and education regarding the mobile response system is we educate particularly schools on the healthy using mobile crisis, why it's healthier for kids, in particular, educating them on the kind of the school to prison pipeline if law enforcement is called. And so that's part of our general outreach and education. But we also developed a program a number of years ago now with the McCarthy funds, juvenile justice funds, and we've sustained them on the general state funds now, that we take the highest, the schools with the highest number of law enforcement calls and school-based arrest, and we target them every single year for what we call our school-based diversion initiative, or SBDI. We do have a website, ctsbdi.org, that has a toolkit that anybody can use. It's a very simple process, and basically we do some professional development, again, under helping teachers and staff understand the difference in the developmental needs of kids and why a mental health response is better than a law enforcement or even an ambulance and an ED response. And then we track all of their exclusionary discipline. We track expulsions, suspensions, detentions, And we feed it back to them in a monthly basis and continue to press the need for mobile crisis. And we've seen dramatic changes from the most dramatic was 90-10, 90% law enforcement, 10% or less mobile crisis, to that same district going to the same school going to 90% mobile crisis and less than 10%. So I think our statewide average of the flip-flop is a 30 to 40% reduction in use of law enforcement and increases in mobile crisis instead. So it's a very simple program. It's easy to do. It could be self-implemented. I would encourage people to take a look at the toolkit because it's really well developed. So we're proud of that, and we think it works really well. And we've been highlighted for that diversionary activity for some time.
I would say that not only the professional development, but that data feedback is so critical for schools being able to see the difference, the benefits. Have you found that to be true?
Yeah, if you run their data specifically when you run it by race and ethnicity and you show it to them, it's somewhat shocking. Schools has the data. What we found is doing really simple data dashboards, so especially visuals with good aids. It's shocking to them to see it. And the other things schools don't do very often on their own is to run it routinely, like monthly. So that's what we do for them. The biggest thing is getting them connected early on, doing the professional development days and getting them to get the data to you timely so you can get that information back. Once you get back through that phase, it's really, really beneficial.
So real quick, that's a slight diversion of the questions, but Alexandra and Jennifer, do you have any thoughts in terms of the matrices that you're doing and the data feedback loops? Is there something some metrics that are being gathered as you start doing that that might be critical for participants to hear about? Alexandra, do you want to jump in?
Sure. So for out of our Marcus Alert stakeholder group, there actually was a work stream that was developed called Equity at Intercept Zero. And this is referring to the sequential intercept model, Intercept Zero. And so out of that was a grant program that we have funded with ARPA funding. And essentially we put out a request for applications or proposals asking for peer-led or BIPOC-led organizations to apply for these grants with innovative projects that could help develop the crisis continuum and also promote equity at community services level. And one of those projects is actually a data project, and working with Isabella Health Foundation. We've been working with them over the past year as they've been developing essentially this data feedback loop, examining our crisis system, pulling all of the metrics, and looking for specifically disparities. And they're not just looking at our crisis system, which we are in the process as a state of developing a crisis data platform, which will house essentially all of our crisis services. So it's the platform which 988 operates off of. Mobile crisis services are dispatched off of that. Our bed registry lives there. Our community behavioral health services will utilize that platform as well. So it's this large system that's in development still. So all of the data is not yet fully there, but also this data project that's in development is also reviewing EMS data that the Department of Behavioral Health and Developmental Services does not obtain, but they're looking comprehensively at law enforcement data through the Community Policing Act and other sources to look at the system as a whole and really see, are the efforts that we're doing, are they actually making the intended impact or having that intended impact when it comes to getting calls from 911 to 988, but also when referring out services such as mobile crisis or someone going to community stabilization or or any of the other alternative services that are part of the crisis continuum as well.
That's a great point. Jennifer, in terms of Los Angeles County, what are you looking at in terms of feedback loops? I know when it comes to call codes for 911, it can be incredibly challenging to navigate. Is that something that you all are looking into, the codes, some standardization? Because I think, how many PSAPs do you have? You have tons.
Many. Don't we just have too many. That's why it's just overwhelming, even when I think of the numbers. And I think that is one of the greatest challenges here is you're talking about so many different PSAPs, right? So many different law enforcement agencies, so many different perceptions and feelings. The good news is, I would say here in LA County is I think there's overwhelmingly this shared vision of where we want to go. It's how we get there that I think really becomes the challenge. And so while we developed, with broad stakeholder involvement, a triage tree, level 4 calls, you need law enforcement, level 3, you need field response, level 2. But that's pretty high level. And so we need to really look at the data. We need to get into the weeds, talk about scenarios so that we can develop those standardized procedures and protocols. So if a call comes in, we are all in agreement on if that should be a level 4, level 3, or level 2. And I think to do that, we need data to inform the conversation. And I think a perception might be, and I'll say might be, is that law enforcement is involved in all of the crisis calls. But then we can share data that shows that we're on any given month, we're going out on upwards 12,000 crisis calls, and 99% of them, we do not need law enforcement at all.
Right.
And I think that type of statistic and data is good to bring to the table so that law enforcement is aware of oh yeah, you guys can handle some of these crisis calls, or maybe even some of those calls that maybe they didn't think they thought law enforcement was needed because they're looking out for the safety of everybody. And so I think just getting that data helps inform the conversation so that you can all have the discussions, but then you have the data to back it up or to say, well, I know it feels that way, but when we look at the data, X number of our calls have these factors in common, and we don't need law enforcement. We're able to handle this without you. But these types of calls, we do need law enforcement. And then how are we going to handle that together? And so I think that data becomes critical. I think also for planning purposes, where do we need teams? Where do we need, better connections, because those aren't, they're not working, or maybe we're getting the calls, but transferred, but then we're just transferring them right back. So I think that also planning and training as well. The data is just critical. And then, I think equity just has to be the cornerstone of everything we do in this area. And so we might not even know yet where that's going to come into play. And so we have started in our dashboards incorporating race, ethnicity, language, age, location into all of our metrics, including how many individuals are getting hospitalized when we go out into the field. You just never know where maybe there is some bias that you weren't aware of.
And I think another area would be who is getting a mobile crisis response versus law enforcement being pulled into a response. So that leads us right into our panel question number 6, which is racism and disparity are pervasive in all systems, including healthcare. To ensure that 988 functions as it should, equity must be part of the crisis redesign from the start. You've talked about this, but if you could flesh out how Los Angeles has worked to really rectify inequity. And like you said, those data feedback loops to not just have it as an aspiration, but something that you're constantly, like you said, a touchstone that you're coming back to over and over again. What is the thread throughout from the beginning of the redesign with equity as the focus?
So I think the thread, or kind of the starting point, is going to be that in that 4-level matrix, developing a standardized screening tool that is free of bias. That's not going to be an easy task. We're working with some of our experts on that. I actually have a meeting today where we're going to talk about how we're going to do that. But I think that screening tool, whatever is developed, needs to be a critical piece, is looking at ensuring that those questions do not have bias built into them. I think the other piece is, I think the big unknown right now, or maybe it's not unknown, is we know there are certain populations that aren't even reaching out for help, right? And that could be because of fear of the police. It could be they don't even know about our service. It could be for a whole host of reasons. How do we start building the trust with those populations in those areas? You know, is it getting out there, having peers in the field, educating about these? But I think that's a whole other piece, is making sure that those populations that have had that racism, right, the disparity, so they're not even reaching out when they need help. How do we start bringing them back into our system and trusting that we are going to provide them services in a caring and thoughtful way, that we're not further traumatizing them? And then I think, you know, kind of on the back end, then it's always constantly monitoring and planning in our systems to account for those different groups in our system. Here in LA, you know, we have just 13 threshold languages. That's our baseline for language capabilities, 13 different languages. With the workforce challenges that we're having in the mental health field, as Alexandra alluded to, is, you know, we're struggling to even get teams, let alone teams that can speak the different languages, that we can make sure that have sign language capability, all of those things. So how do you balance making sure you have the right team while you're also experiencing a challenge with just capacity and retention of staff? And I think there we are building out a crisis training academy, having diversity, different disabilities, different cultures being a cornerstone of that training, so that we can train all of our staff in the needs of different populations when they go out.
So that there's cultural competency and cultural
Absolutely.
humility.
Absolutely.
So when you talk about the screening tool, is that really for 911, or is that screening tool going to be
Everybody.
applied across the board? That's great.
Yeah, the goal is that we can you know, that's always the lofty thing, is, but our plan is to have it so we can all come to agreement, setting best practices in diversion of calls to different levels of care, and so that we're all looking at the same things. So if I call, and again, I think this is a challenge in all areas, is you want to have services that are localized to meet the needs of the community, but in the same sense, you want people to be able to have some expectation of, no matter where I am, I'm going to get a somewhat standard response. I know what to expect. I know where to go. And so you have to balance those two things. And so we're hoping that even if we're not going to mandate everybody uses it. I don't think we're in a position to do that. But if we can bring the groups together, really partner in developing it, and then set a best practice for the area, that then it's less work for other people, right? They don't have to redesign something that's already been designed for them.
I love that. Alexandria, can you talk about in Virginia, how from the onset, inequity was a focus of the redesign in order to ensure that marginalized people don't continue to be harmed and further marginalized?
Sure. So I think at the beginning, and really written into our legislation, is the inclusion of those communities that typically are marginalized or underrepresented. And so even at the state level, we had a lot of representation amongst our stakeholder group that developed the plan, from social justice advocates and community members that were just interested in helping to make a difference and inform that plan. One of the requirements that we have for localities as they implement, and I should also maybe explain a little bit about how the localities are being defined in Virginia. So we have 40 public behavioral health systems, or organizations that are part of the public system spread across the state of Virginia. And so those 40 areas or 40 organizations serve catchment areas that can consist of a single county or city or several counties or cities. And so our legislation requires each of those organizations to work with their community partners to implement. So some of them are working with maybe 10 law enforcement agencies and maybe 5 or 6 PSAPs, versus some are lucky to only have one, such as Virginia Beach has, Virginia Beach Police Department, Virginia Beach 911 Center, and such. So it just looks a little bit different depending on if you're a more rural area or a more urban area typically. And so those localities, as they're implementing, they're required to bring their stakeholders to the table. So we recommend to them to reach out to their local community justice organizations, to reach out to individuals who are being served by the system currently, looking at those with lived experience, using their peers and their networks to include those individuals and having a voice and having a say in what exactly do you want to see in the community. A lot of times, I think it's easy to think what's happening in your community, think that you have a good idea of exactly what's going on until you listen to somebody who has gone through the system a couple of times and explaining their perspective of exactly what it feels like to go through that process. Though you might be following what your protocols are and what your policies are, it still has an impact on that individual and they're looking to see change. So that's one of the nice things that actually has come out of the legislation is that requirement to include individuals with lived experience. I mentioned previously that we have these Equity at Intercept Zero grantees. And just to name a couple of the types of projects that they're working on, we have one organization that is the only exclusively LGBTQIA plus recovery house in the state. They've been working on developing a training on dealing with that population and also people of color, the intersection of LGBTQIA plus and BIPOC in crisis. We have a peer recovery organization called Strengthen Peers that is working to develop a network of clinical and non-clinical recovery community organizations as a referral source from 988. So for individuals who don't need clinical services, sometimes that could just be a place where they're going, meeting other people, having groups and sessions there. Some are going to be clinical for individuals that need that service, but making sure they have alternatives to maybe the public system of mental health, which a lot of people have had experiences that might not be great, or maybe they don't want that type of service. We have some workforce projects in development where we're providing clinical supervision to providers of color and those with lived experience also who might have circumstances that don't allow them to afford typical clinical supervision. Also doing some coaching and mentoring for undergraduate students, encouraging more people to pursue their master's in behavioral health care, and a number of other projects that for the sake of time, I don't want to take up too much time explaining all of those. But we're just making sure that there is a focus on prioritizing lived experience, as well as for those individuals who are typically marginalized, underrepresented in services, and are at highest risk of criminalization of mental illness.
Thank you so much, Alexandria. Tim, if you could talk about equity and how that's been a tenet for the statewide youth crisis response program from its onset, really. Could you talk about, I know you've talked about the school program, but if you could flesh out some of what you've already previously discussed.
Sure. So all of our data we've run right from the outset by race and ethnicity, right out from the onset. And one of the other activities that we do every month, we focus on that data and we highlight any disparities in that data and we feed it back to the providers on a monthly basis. And when there are disparities, they're required to submit back to us activities that they're doing to what we call turn the curve to reduce those disparities. And so that's done actively. It's not only in Connecticut done for our mobile crisis, but they do it. We do it across the entire service array. So that's a requirement for all of our providers. So it's helpful. Our mobile response system has the most parity and the least disparity in our service array. Again, we think that because the most important part of that is access and going to where people are at. So that's really important. I want to mention one population that's not often thought about as a marginalized population, and particularly as we implement 988, and that's children in general. And they may not be marginalized as some other special populations are, or the communities of color. But the way happens is often unintentional. We build systems that are really geared for adults. And you really need to be very specific and intentional to address children's needs, under 18 needs. And so I just wanted to mention that. And it does require specialized training specifically around developmental issues, but also like adults, kids don't grow up in a vacuum, and they have a lot of relationships that support them and need to be addressed too. And it's often the family needs support while they're in their crisis also. Thank you.
Thank you, Tim. I think very briefly, if you could just talk about, why it matters that care is going to young people. You touched on it, but what are the barriers? If we're talking about transportation, what are some of the barriers that it overcomes?
The mobile crisis system. Mm-hmm. Yeah, I think the biggest thing is, again, getting there. And the other piece that it really overcomes by Connecticut legislated a mandate that every single school in the state of Connecticut have a memo of understanding with their local mobile crisis system. So, and it was in that process, again, that we educated the school systems on the importance of the developmental response to kids and meeting their needs through a mental health response and meeting needs. For kids, bad behavior is usually a result of unmet need and not in, what happened to a child versus, what it is they did. So we really try to really focus on those areas and try to come from a trauma-informed perspective.
Thank you so much to the three of you for spending this time with me. I'm going to pass it along to Carrie Slatton-Hodges. Please make sure I'm saying that correctly, who's the commissioner for the Oklahoma Department of Mental Health and Substance Abuse Services. Sorry if I butchered your name, Carrie. Thank you.
Thank you. And hello to all of you. As was said, I am Carrie Slatton-Hodges. I am the commissioner of the Department of Mental Health and Substance Abuse Services in the great state of Oklahoma. And so today I want to share a little bit about what we are doing in Oklahoma, kind of our preparation for that, and where we are at in our state in terms of boots on the ground with 988. So with that, I'm going to share my screen. So I do want to do a disclosure in that I am an employee of the state of Oklahoma, and that is my only compensation. So anything that you will see just really comes from that perspective. So in Oklahoma, we are a state that has urban, rural, and really frontier populations. We're a state of about 5 million total population, with about 60% of that living in our large urban areas. The rest is all rural. So in looking at building out a crisis continuum of care, that's something that we needed to be very mindful of. And so this is our roadmap that we have for 988 and really kind of our crisis continuum of care. So when we found out that there was national legislation in the works and that would be going into effect that would allow for one 3-digit number from any landline or cell phone, we looked at our crisis continuum of care, and we had bits and pieces of what we thought would be the ideal continuum, but we knew we wanted the continuum with those gaps filled in, up and running for July 5th when 988 would go live. So we did a lot of prep for that, starting with moving from our state of having several call centers where things would go through to making one statewide call center. We partnered with a group called Solari, who had been operating a crisis line out of Arizona for many years. And we're pleased with that because they had worked through many things through the years. They had great technology already to bring to the table that they could share in doing this work and to get us up and running. So we started with our call center. A little bit of information around that, just as we go forward here, is that to date, so this is since July 5th, our call centers answered more than 18,000 calls and responded to over 5,000 texts and chats. And our average speed to answer is 11 seconds. We have a 99.8% in-state answer rate, and we have a 92% stabilization rate where the end result is that the person did not need to go to the hospital. Now, another part of that continuum then is mobile crisis teams. So one of the things that we knew we wanted to do, even though we had some mobile crisis throughout the state, is that we wanted to make sure that we had statewide mobile crisis capability. So the way our state is broken up is we have service areas or catchment areas where we have community mental health centers. And basically, our state is broken up into 14 regions. So we wanted to make sure that we had mobile crisis that could dispatch throughout each of those regions. And we were able to get that up and running so that through Solari, or our 988 call center, is the dispatcher of those mobile crisis teams. Now, someone could call one of those local providers directly, and they could send out mobile crisis. But what we really wanted to add to this new continuum was where the 988 call line could dispatch these mobile crisis teams anywhere statewide. We also wanted our call center to be able to set up appointments for people, as well as do a follow-up with each and every call that came through. And I'll show you, we have a public-facing dashboard that we use right now that where people can go and see just kind of up-to-the-date information around our call center. So you can see the 30-day crisis call volume, the answer rate, the stabilization rate. But one of the things that I have found interesting is the reason for calling. And the number one reason for calling so far has been self-harm and suicide, suicidal ideation or thoughts or action. And that is really important to me as a commissioner and to our state as a whole. And that suicide rates have been, and this may be the case where you're at, are very stubborn to move. And we wanted to be able to set up this continuum to make a huge difference in Oklahoma in terms of the number of completed suicides. So this information showing us that 25% of the calls are related to that is very helpful. You can see how the call volume has kind of gone up and down, hovering around 3,500 a month. And one of the other things that you can see is who is calling. So 61% of the calls are a person calling for themselves, with 17% being family members, which I know some of you had questions about, and then kind of breaking down from there with about 4% being a behavioral health provider, and very few actually being police calling 988. And we can talk a little bit about more about that as we go along. You can also see our dispatch volume by month. This is for mobile crisis teams. These are the number of mobile crisis teams sent out by month. And Solari then makes that determination in terms of when a mobile crisis team should go out, when it's safe for that to happen, etc. Okay, let me get back to where I was. So the other thing, and I'm hoping that we are back on the correct slide and you can see the roadmap again. One of the things that we do in Oklahoma that is a little bit unique to us is the use of technology throughout our state. Now, when I say technology, I don't necessarily mean just providing a telehealth service. What we have done throughout the state is we put iPads in lots of people's hands. And these iPads have a software on them that is what we use throughout our system. And there's a number of different ways that we have done this. But one of the things that we have in Oklahoma is that every law enforcement vehicle across the state has one of these tablets in it. And that was supplied. Really, we first started this with a number of law enforcement entities and kept data around that. And then our legislature chose to fund this initiative so that every law enforcement vehicle across the state has these tablets with them. And what that does is it enables law enforcement, if they're out patrolling or in the field, and they come across a person who they believe may have a mental health or addiction issue, they can push a button and a mental health professional pops up on the screen. And that person can do a couple of things. One, they can help guide law enforcement into what the next best step would be. Or they can hand that tablet to the person that they have come across, and that licensed mental health professional can start having the conversation right then and there. Oftentimes de-escalating the situation, linking with services the next day, or doing an evaluation and assessment if necessary, and letting the law enforcement officer know that, yes, this person needs additional help. Here's where you need to take them, and we are waiting there for you. Now, in addition to that, we put technology in the hands of many people that we serve. And we do that for a number of reasons. And as I said, we have a lot of rural and frontier areas in our state, and it can be difficult for people to get to care. And we had found that when we place technology in the hands of people that we serve, that engagement with treatment goes way up, no-shows go way down. And in fact, those persons, the way they're set up, you have your treatment team on one side, but there's a big button in the middle for emergency crisis. And we find that people will then utilize these tablets when they feel like they're in a crisis, or when they feel like it's 2 a.m. and they're not feeling quite right. And then we answer those across the board to make sure that people have someone to talk to through technology. Now, these are persons who are involved in our system already, where on the 988 side is more people who have not connected, who don't have technology in their hand, who don't have a treatment team or persons that they're linked with. One of the other pieces of our crisis continuum of care is getting people to levels of care that they need. And so a year ago in November, our legislature passed a bill that said, whenever a person needs to be taken for an evaluation or needs to get to a higher level of care that law enforcement had been transporting, that would now fall to the Department of Mental Health and Substance Abuse Services to arrange transportation. We were pleased with this because what we know is that being transported by law enforcement for a mental health issue can be very stigmatizing. And most law enforcement entities, through regulations, either city or county-wise, are required to put people in handcuffs in order to place them in their car and transport them. So what we find across our nation is that persons who have a behavioral health issue are being handcuffed, placed in the back of police cars to get their medical care. So we were pleased with this bill, and we have been doing that for just a little over a year now. And it's been really amazing. And I'll show you a few statistics on that. We have transported over 13,000 Oklahomans to date through this, what we call ride care, which is a different way to transport persons with behavioral health issues. And that transportation has done over 1.5 million miles in 1 year. So this went into effect November 1st. We just crossed the 1 year in this 2022 November 1st, and we did over 1.5 million miles in that 1 year, which is pretty amazing, I feel like. Now, the last piece of the continuum that we're looking at, and so I did want to point out, we have over 24,000 enabled devices across our state. And we've received approximately 95,000 inbound crisis calls through our tablets. And the average duration on that is about 27 minutes. So we have multiple ways by which people can have a good disposition of a crisis, whether it be through 988 or whether it be through technology. But what we also want is when people do find themselves in crisis or do need care 24/7, we want that to happen. And so we have a system in our state that is twofold, and you've heard some of this mentioned earlier. One is that we have urgent recovery centers. So these are locations, just like you might find a physical urgent care, these are for behavioral health, where you can go to 24 hours a day, 7 days a week. A family member can take you, you can come in yourself, law enforcement can bring you by, and you will be able to have your needs met. Number one, you can have evaluation and assessment, but that's not the end goal. The end goal is that we can provide for you 24/7 what it is that you're needing to be able to be stabilized. So if, say, you're needing medication, or you're needing to get away from a really stressful situation, or you need to talk to someone face to face, or you need to work with a case manager to look at what the challenges are in your life that are causing the stress leading to symptoms, we can manage all of that 24/7. And we added 22 new urgent recovery centers this past year, and you can see those on the map here. Now, in addition to that, we are a crisis center state. So we have what we call crisis centers, which are a place that has short-term beds that we want to have out within the community, so that you're not needing to go out of your community to a hospital stay. That first you have the option to having your care and treatment at an urgent care. But if you do need to go to a higher level of care or be in a treatment bed, that we can do that around within your community as well. And again, this is also something that our legislature has decided to invest in, and we're continuing to open more of these each year so that we have our entire state saturated with urgent recovery centers, where you can have that psychiatric urgent care, where we have crisis units. And then the end of that continuum would be if you needed to go onto a hospital bed because you have maybe more treatment resistant types of needs or a longer term stay. And so really that is our crisis continuum of care in Oklahoma. Again, you can see our roadmap. So we want a facility nearby you. We want someone to be able to talk to you, come see you if needed, a way to get there. And this is what we have built over the last year, and we're very excited about the work that we have done and that we will continue to do as time goes on.
Thanks so much, Carrie. It's a real pleasure. And Carrie and I have talked together about the different approaches that we have and how the great work she's done with technology. I'd like to I'm Ann Sullivan. I'm the commissioner for the New York State Office of Mental Health. And I'm going to share with you our experiences so far in New York with our crisis 988 and with our crisis continuum. So let me share the screen. I think this should work, hopefully. Okay. Great. So the first thing is just to say that in New York, we have 13 active crisis contact centers, but they all do connect with each other, and we are getting data from all of them. Largely, this was put together because of the system we already had in place, and rather than become a totally one contact center across the state, we've kept the connections with those contact centers. We have 62 counties, and some of them were very embedded in their counties, and it's important to respect those county connections, but they will all be connecting to us and all be providing us data over time. Just to say, the financing for New York has been, we never put a tax on our cell phones. There is $60 million each year in the budget to support the 988 calls. And then we had some startup dollars, which came from the block grant and SAMHSA. But that $60 million is embedded into future budgets to support 988. All 62 counties in New York now do have coverage by 988. And we've seen our call volume significantly increase. We get about 93,000 calls in 6 months, and 3,400 more calls a month than we had before. We're designing this so that we can definitely deal with at least double that increase if we have to. And so far, we're hopeful that by the end of next year, we'll be able to we're about an 82 to 85% in state answer rate now, that we'll be at close to 100% by the end of next year as we grow the capacity in the crisis centers. In the crisis call centers. But just as in Oklahoma, you can only go so far with a call center. While 988 is the key thing for people to contact, you need a system that follows up afterwards, and then a system that ultimately can enable individuals to go from your crisis system into your basic structural mental health system across the state. So I'm going to talk very briefly about our mobile crisis teams, our crisis residential programs, stabilization centers, and our comprehensive CPEPs, which is an emergency room program that we have across the state that we're going to be also expanding. And these enable a 988 to truly function. When someone calls 988, whoever works with them, while in our state, similar to other states, about 60%, 50 to 60% of the calls can be answered with counseling. But the others that do require a referral or sometimes high-level mobile crisis to come out, you need to have your system in place. One important thing, though, to remember, and this has been difficult getting the word out, is that it is a counseling line. And for people to know that calling 988 is not just for referral or to have a mobile crisis team come out, but the 988 is really a crisis counseling line, with most of the calls lasting anywhere between 20 minutes plus, and many of the issues being dealt with at that counseling line. And that's a real improvement in terms of people having access to that kind of service right away by just calling 3 numbers. So mobile crisis development, we've been growing over the years. And by the end of next year, we will have active mobile crisis in all of our counties across the state. It's been a growth. It's been, as was mentioned earlier, it's important to know the mobile crisis teams are called for everything. So we have over the years increased our capacity to work with youth issues and children's issues, substance use issues, as well as mental health issues. And more recently, development for those individuals who are duly diagnosed with a developmental disorder and a mental health disorder. Getting that level of expertise in every mobile crisis team is a challenge, but we're working on it. So it's important to be keeping track in your data of who's calling, which everyone has been talking about, and what kinds of training and services you need to keep expanding so that you can respond to anyone who calls in. I think one of the worst things is to have someone say, well, we can't handle that. That's not what response teams should do. But I think often we need to make sure that people are trained to do it well and to use best practices. So mobile crisis is something we are growing across the state. Our response time now in our mobile crisis is probably across the state pretty much 20 minutes to 30 minutes, but we still have some outliers. So we have put forward a policy that says no more than 2 hours, but most of our mobile crisis teams now are responding much sooner in terms of 20 to 30 minutes. We've also put out a major initiative to help mobile crisis teams know how to bill. Now, all this sounds a little mundane. It's very important if you're going to keep a system going over time and space. It's important to get state dollars, but state dollars and state budgets change. I also tend to feel that insurers, both Medicaid and private payers, should be responsible for the services that we're providing. So, and actually in this year's coming legislation, we are putting in that commercial payers have to pay for mobile crisis services in New York State. We're going to try to put that in legislation. We did get it in legislation for our stabilization centers, and also Medicaid, of course, pays. But it's very important to have a system. So this is how you bill, how you get services, and that's something that we've had a major initiative with mobile crisis. We have crisis stabilization centers. These are growing across the state. We have 12 of what we call intensive and 12 supportive. And basically, they are 24 hours, 7 days a week centers that offer voluntary person-centered crisis services. We have probably half of them. All have gone out to bid now. Several are up and running. We expect we will have it completed probably by the end of next year or mid-2024. They are incredibly infused with peers and individuals with lived experience, because it's critical, I think. Even the supportive ones are actually run often by peer organizations. The more intensive ones are embedded with peers and peer family advocates, peer youth advocates, and adult peer advocates. So very important, I think, in crisis services. So these are two models which are doing across the state. They have not been in New York before the last couple of years. They also will be providing on the intensive side. They do provide, which is in the right-hand column, they will provide psychiatric services and medication, and they will do buprenorphine induction, other substance use inductions as well, and also prescribe psychiatric medications on the more higher level stabilization centers. So they're kind of sort of like urgent centers, plus with the ability for someone to be there for 23 hours. These can then connect to our crisis residential programs, which are again growing across the state. These are voluntary. Someone can stay usually for up to 28 days, but until we get them stabilized somewhere else. The crisis residential we have for adults and for kids, and the youth crisis residences, which we started a few years ago, have been incredibly successful in helping youth stay out of the hospital, avoid inpatient services, and continue to stay in school. We're trying to have these in as much as possible in high need areas where the youth can go from the crisis residence to school. They just have a period of time with extra therapeutic support, and it also involves a great deal of family work. So the crisis residential system is something that we're growing. And again, some of them are more high intensity than others. Some are lower intensity. And again, trying to fit them to the communities and the community needs. So this is the current landscape, and we're going to be doubling them over the years, but they will be across the state. One of the challenges, which Carrie talked about too in Oklahoma, when you try to do things statewide, it's often a process. You also have to tweak things to different neighborhoods, different areas of the state. New York, despite having a big city like New York City and very, very concentrated areas, also is a very rural state, upstate. So it's been a challenge in terms of designing some of our services. Now, just to talk a little bit about approaches to community in terms of the importance of involving diverse communities. I think that one of the things that we learned in a big way during the pandemic, and we had about $100 million grant from FEMA, and that grant provided us with the opportunity to reach into the high need areas across the state. But one thing that became clear during that was that while we did a lot of advertising, we did a lot of outreach, especially our hotline, which we had at that period of time, was really not well utilized by our marginal, underserved communities, by our Black and Brown communities, by our LGBT communities. It just wasn't. It seemed to be largely, when we looked at the data, individuals from lower middle class, but primarily white. And we thought about it, and we looked at what we were doing, and we realized that we weren't doing the kind of outreach and connection to our communities that would make them really use that number. And I think we have to be careful that we do the exact same thing with 988. 988, while it's available to everyone, and we're doing some of the publicizing, there's still a lot of distrust and fear in our communities about dealing with a number that could possibly link them to 911 and possibly link even to a law enforcement involvement, or just a general kind of not understanding what calling for a behavioral health problem is. We want 988 to be something that our communities use, that they trust, and that they also use early. Not waiting for a crisis, but early to get assistance if they don't know how to navigate our systems. So we're going to be doing a lot of work. We're doing planned focus groups. We're working with communities. We're out there saying what will work for you when we try to increase the use of 988. A couple of examples. We've established a a group in various parts of one of our new American communities. We have a group. We have a special Asian work group. And then we have a special program going on in East Flatbush in New York, which is a primarily Black and Hispanic community. And there we are working with a social service agency, the East Flatbush Village Inc., and we're doing intensive work with them about describing what our crisis system is, what's available, how to utilize the crisis system. And depending upon where, I think we have to do this groundwork. I don't know that we have always done this as a state when we have put out new services, but if you're really going to deal with disparities in care, you have to really do the groundwork of that kind of in-community outreach, in-community connection to make sure that everyone really has access and that you're doing it right. And I think that kind of feedback is something which we're also setting up. We will have ongoing community advisory boards helping us. We will have ongoing feedback from various communities about whether this crisis service is doing what they think they need in their community. And again, another Asian American Asian network in New York City. We have lots of issues with language, and we're working very hard on dealing with that, whether it's what we print, but also on our texts and chats and everything we have, as Los Angeles had said earlier, lots of languages in New York, and the availability of staffing this. You would love to have individuals be able to answer that phone, that you could be able to refer to an in-person, not through a translator, to be able to talk with them about what's going on. But because of the multitude of languages we can't, we're pretty well, in some of our communities, pretty good at being able to have a Hispanic, someone who speaks Spanish available. But it's tough with some of the other languages. In some of our Asian communities, we've been pretty lucky with Cantonese and some of the others. But often we use language interpreter lines. Not the best thing, but what you really have to do when you have no other options. Oops, going the wrong way. So again, responsiveness to communities. And then a couple of challenges that I just wanted to go through briefly and just say where we're going with them. One is assuring that all New Yorkers are really aware of what 988 is. There's still not a lot of awareness that 988 is truly a counseling line as well. We do get a lot of crisis, we get a lot of referrals, but it can also be used by a parent who's worried about their youth in school early on to get some advice and maybe some help. It can be used by someone who's elderly who is feeling isolated and depressed and needs some connections. So we're really trying to get the message out that 988 is there for everybody, and to use it as well as in emergencies. How it's going to interface with 911 is a challenge. In some of our counties, we have begun the process of a really tight connection between 911 and 988. In Broome County, one of our counties, and in Dutchess County, where they're working together with 911 on a triaging system where the actual 911 operator can connect right away to 988, understands what 988 is. And we're going to be growing that across the state, but it's not very tight yet across the state. And I think the understanding of hopefully what 988 is will help decrease that volume that goes to 911 over time. And that's our hope, but we still want to have that connection so that there maybe can be an easy movement of individuals. And in some of our counties, we're working on that. The other is the connections from the crisis system to the rest of the service system. And we were very blessed in this year's budget with our governor to get a major expansion in all our outpatient services. We depend largely on the certified community behavioral health centers, which have come up in New York, and our baseline clinic service across the state. And we have dollars to expand all of that so that we won't have wait times for individuals, that individuals will be able to move easily from a crisis intervention of some sort, whether it's our crisis stabilization center or a mobile crisis team, to the integral outpatient services that are needed, and whether it's our intensive outpatient program or our basic clinic system. But we needed more capacity. Now we have the capacity, but we need the workforce. We're in the process of doing a lot to recruit that workforce, but it's really very critical. We're also developing a statewide data system, which is in process, where we'll be collecting all this data. One of the challenges is connecting the data from the crisis system to the data from hospitalizations, how many people are in the hospital, other kinds of connections which we need. And then ensuring ongoing feedback from clients and providers. This is something that you really have to build in. And one of our staff got very creative. One of our peer staff said, why don't we have an easy survey like other people do when you leave that will say you can just fill out something on a kiosk in the stabilization center. So we're going to be setting that up so we get real-time feedback. Did you get what you want? Was your meeting here helpful? Get feedback right away so we can continue to look at and design what we're trying to do over time. And then the question of geolocation is something that is an issue. We're looking at something called maybe geo-routing, if that could be acceptable, which would give an idea of where the call is coming from, but not that could be coming from New York, but it wouldn't say exactly where. So for people's concerns about privacy, et cetera. So we're looking at some of that. And I know there's other groups that are looking at that. And then lastly, payers. I know you had a whole thing about the financial at an earlier point, but I think this is very important to states. Basically, you want to be able to have a continuum like this. And I think you want it to be able to be sustainable past just a lot of state aid. And you also want it to be sustainable, I think, by insurers and for insurers to take their equal part in paying. And by that, I mean commercial insurers, that I think often the burden falls back to states to give deficit funding to these kinds of services because it's so difficult to bill commercial insurers when everyone should have the opportunity for these services and be paid for by the insurers that they count on. So I think I will just stop there just to say that this is an incredibly exciting time. I think 988 was the game changer everybody said it would be, and that the ability to respond to that in New York State has really been great. So thank you all.
Allow me to introduce myself. My name is Robert Heinsohn. I'm from the National Institute of Mental Health. For many years, I've been involved in services and intervention research and the implementation of evidence-based practices into public health settings. And it is a real pleasure to be here today with you all. I want to congratulate each of the presenters today for really sharing important and useful information with a broad community that is looking to move forward with the challenges and the promise that the 988 crisis service legislation provides. I have been collecting questions as they have been posted today and organized them a bit. So what I'm going to do is we have about 20 minutes for questions. So I'm going to throw these out, and to any of the presenters who would like to respond, please just turn on your camera at that time and feel free to speak up. So there were a few questions that centered around establishing the relationships that create the crisis care continuum, and what might be lessons that you have learned about establishing those relationships that would be useful for others to know. So for example, one question was, describe how you have approached law enforcement, the 988 community approaching law enforcement and developing a positive relationship. Was there any pushback from law enforcement? And if so, how did you positively resolve that? So let me throw that out, and whoever would like to share their ideas about that.
This is Commissioner Slatton Hodges, and I would start by saying, you know, obviously developing relationships with partners across the state is not something that should happen just because 988 started. It's something that is, you know, ongoing and we've been working on for years. And so, for example, one of the things that we do as a partner with law enforcement is we do crisis intervention training across the state. We go out into communities, we train law enforcement in evidence-based practices for interacting with persons with mental illness. So we have a lot of relationships already, and we have relationships with community partners. And what I would say is that when we first started talking about 988 and its link to the continuum of care, law enforcement was thrilled and excited because they have struggled on their end with being the source of very high volume of calls from persons with mental health issues and not knowing exactly what to do with those. And really their only option was to do a police or law enforcement response to that call, knowing that that may not be the best way to handle it, but that was the only tool that they had in their toolkit. So I would say that in general, it's been, they were very excited, really excited about having alternatives. And they have been as much of a promoter of 988 as anyone has been. But so I would say you don't, ideally you're not starting relationships right now with this initiative. You're continuing relationships, but building on those relationships with the additional tools and things that you're able to bring to the table for all of these different partners.
Thank you very much. And it sounds like a lesson from that we might draw for other states and municipalities is find the places where the relationships have been established and perhaps use them as a way of modeling those relationships for other areas where perhaps they have not yet been developed or are emerging. Any other takers on this question? But that was an excellent answer. So
this is Jen from LA County. And I just want to say is I think this is such a critical piece of all of this because we, as much as we want the response in a crisis to be a mental health response by mental health professionals, there are absolutely going to be situations in which we need law enforcement to protect our staff as well as protect the individuals in crisis. And so, I think the partnership just can't be undervalued, but I think it's coming together and sharing, making sure that message is clear, that it's not, oh, these are just mental health problems. Because I think sometimes there's situations where it's something that both parties need to address. So having that shared vision, but then getting into the weeds and talking about specific cases. And I'll just say I was on a call with a law enforcement individual while he got a call from a school of a child threatening to jump. And so they went out, but then once they were on the field, then it determined that situation, the kid was only a couple feet high. And so maybe law enforcement was no longer needed at that point. And so we need to really have those conversations about individual cases, walking through, because you have different perspectives and you have different priorities in those situations, and you need to get to a shared understanding of what the best way to handle that situation is.
Yeah, and I'd just like to add that the training and the connections have to be ongoing and kind of intense, as new police officers come on or new law enforcement come on, it's easy that people don't get trained and that they don't have the experience. And then it only takes a few incidents for people in neighborhoods not to trust the system. So I think it has to be an ongoing connection. It has to be pretty intense, and you have to make sure that the training there is really available. And it's very local. I think you have to really understand your county, your local sheriff and your local law enforcement are very critical in that partnership.
And one of the things that Commissioner Sullivan mentioned earlier, which I think is incredibly important, is to know that there is not a one nationwide seamless smooth way to connect 911 and 988. And so what we are having to do, all of us as part of this, is to go to each county, to each city across our entire states, work with their 911 dispatch, train and come to an agreement upon what the matrix should look like. When should it go this way? When should it go that way? And so we are doing that on a town by county basis across our state. Now, ideally, at some point in time, there will be some national work done that enables that to be more smooth. But right now, we're all doing that department by department across our states.
And it's wonderful that you're sharing these experiments that you're running in the various states, so that people are able to learn from them and perhaps borrow from your wisdom. we had a number of people discussed the challenge of developing a responsive workforce in 988. Tim, you talked about some of the things that you're aspiring to in Connecticut about having a workforce that looks like the people being served, speaks the language of the people being served. So there was a question here. We need incentives to build our workforce. Both recruitment, retention, and ongoing training are all equally important. Are there lessons learned that the speakers would share with the audience? So this is about capacity building for the workforce. Tim?
Yeah, I'll jump in. I think one of the things, what we've learned is that it's not only about salary, but salary is important. If you are way under the salary, you need to bring that up. And so Connecticut has been doing kind of across the board look at all the Medicaid reimbursement rates, a number of which have to come up substantially. So that's one thing. But the other part, and what's been really difficult, particularly in the last couple of years since the pandemic with the shortage of workforce, is to let workforce development opportunities to drop off because people are so busy. But we think it's most important to get them off the lines, continuing to feed them with competency development and training, workforce development opportunities to get together, to talk about what's going on and to support one another within that context. So within the context of workforce development, competency development, also that self-care and taking care of oneself throughout that process and supporting their development and their growth. And don't assume that because everybody's busy and short staffed that they can't do it.
And I would say in terms of workforce as well, as something that many folks mentioned, is in our state in particular, we've had a strong push for many years now on the development of the peer workforce and its value in terms of what we do. And one of the things that we learned early on about really engaging persons with lived experience within this continuum is that persons with lived experience come from all walks of life. They come from the hard of hearing community. They come from your minority communities. They come from having lived experience with incarceration and mental illness. And so by really leaning in and developing that particular workforce really helps you in terms of the diversity and the connectivity to communities across the state. So that's something that I would say, if it's not something you're doing strongly in your state, I just would encourage you to do. The other thing I would say is that in our state, we are now statewide with our CCBHC model, which is our comprehensive community behavioral health clinics. I think I have the acronym right. And it allows a different type of payment model than we've ever seen in behavioral health, so that it is based upon the cost report of the provider. So as they, if the market adjusts and it's going to take X to fill those positions and to train those positions, that is part of your cost report, which then sets the rate that you're able to be paid or reimbursed by Medicaid and or the state. So that is something, as you look to the future, the CCBHC model is a big shot in the arm for the development of workforce and being able to retain and recruit workforce.
And now there are over 500 of those programs across the nation, represent a real resource for us to build upon. Alexandria, I was very impressed with the way that you were talking about how you're weaving together so many different local circumstances, and almost on a location or locale by locale basis, pulling together this coordinated system of care. I'm wondering for you, so this idea about developing a workforce, such diversity in Virginia, and I'm wondering whether there are any special insights that you have that you could share with us about how you're managing that.
Sure. In particular, I know I mentioned one of our grantees that is doing workforce work. Though we do have several workforce initiatives that are happening at the state level. This one I actually oversee. And so the Equity at Intercept Zero grant, not only are they doing coaching and mentoring with current students and providing clinical supervision to residents, but they're also working with our state's 4 historically Black colleges and universities, or HBCUs, to work with those students who are typically not going into, or I guess the rate at which they're going into the workforce is a lot lower, even though they do have master's programs in behavioral health fields, as well as undergraduate programs as well. And so they've really been doing a kind of deep dive with students and also with the administration, reviewing curriculums and comparing them with some of our other institutions in the state. Some of the insights and things that I've learned from them, though they haven't completed their full report yet as a deliverable, but just learning about the access to what's out there. One of the bigger areas is we have a large university in our state that has several master's programs that's available to students. However, only some of their master's programs are actually eligible for licensure. So a lot of students would be going through these counseling programs thinking that after they graduate, they could be a licensed clinical social worker or whatnot. And then only to find out that this is actually not a license eligible degree program. And so looking at things like that, where making sure that students know what their options are up front, and that's where that coaching and mentoring comes in too, or just learning about what the next steps are available, exploring with our public mental health agencies, what type of internship opportunities exist. A lot of them have internship pathway programs, but they'll just be with certain universities. So making sure that we're opening it up to all universities, including our state's HBCUs that don't really have any of those established partnerships. So making sure that they have access to those same opportunities and that they're recruiting from that student pool also is important. So, I mean, they're really learning a lot of information, and this is one of the benefits of really partnering with these smaller organizations, is that they're finding very innovative ways to get in with these universities and with the students, because they're talking to students that look like them, who are more likely to, kind of give more insights into what they probably usually would tell maybe somebody who was working from the state or something else. But they're learning a lot, and it's a lot of helpful information that our local community services boards, which are our public mental health providers across the state, can take and actually use to increase their workforce and increase retention, looking at company culture, experiences that these students have had when they've done internships or have done have been residents at these organizations, and maybe the lack of supports or certain circumstances that they just needed more that they weren't getting from there. So this, I think it really falls under not only increasing that recruitment, but that retention too. How do you get those people into the workforce, and then how can you keep them by supporting them appropriately?
You have a very long view on this on this issue. It's wonderful. Stephanie, I've been told we have 2 minutes left. You did such a wonderful job in pulling together that first panel. I'd like to give you the opportunity of the final closeout on the question and answer. You have 2 minutes to say to tie it together in any way you like.
Well, thank you. I think, every state is in a different place, but struggling with similar issues. When we talk about law enforcement, unfortunately, I don't think all communities are at the same starting point. And so I think what would be great for participants to hear is, how do you build those out? I mean, trust is really dire in those relationships. And how do you get those relationships started? Does that mean having behavioral health teams that are on the 911 call center floor. What does that look like? Should it be virtual? Should it be in person? What do you see in terms of structuring and building out those relationships? Because without law enforcement, diversion from 911 is going to be challenging. So, and all first responders, not just law enforcement. We say law enforcement all the time, but it's not just law enforcement. You have fire, you have EMTs, you have ambulance. So if you could talk about what that looks like in terms of scaffolding those partnerships.
Terrific. Again, thanks to all of you for sharing this very rich experience and knowledge that you have. I will now turn it back to Professor Alegria. She started us off on Friday, and she's serving a bookend function by closing us off today.
Thank you so much, Robert. This was, as you said, a wonderful, wonderful second webinar. We heard from Virginia, Margarita Alegria. Let me start saying I'm Margarita Alegria. I am a professor at Harvard Medical School and the chief of the Disparities Research Unit at Mass General Hospital and the Mongan Institute. We started this webinar hearing from Virginia on their Marcus Alert system established in 2021, which includes a statewide framework for coordinate 911 and regional crisis call centers to establish a behavioral health response. This was fantastic because they mentioned about the tax to support the efforts and even the House Bill 5043 that they put in place to make sure that they have training for law enforcement teams to do this work. We then follow with Connecticut, who share their successes of their 12-year-old crisis services for children, youth, and families through face-to-face assessments and substantial response times. And this was important because, as Tim Marshall said, you know, parents are really important connectors to that response in crisis mode. So it's very important to do this in face-to-face assessments and be intentional on something very different for children versus adults. We then follow with Jennifer Holman, who really talked about the substantial response times that, fast response times that have been done in LA County, and share the redesign of their crisis response system to better be coordinated with 911. Commissioner Slanton Hodges then shared the continuum of care in Oklahoma while highlighting the challenges of getting rural areas services and services in a fast way. Challenges were met through a partnership with the private sector companies to provide transportation services when someone experiencing a psychiatric crisis called ride care. This is an integrated technology by providing devices that then include access to healthcare providers and will be adding new urgent recovery and crisis centers statewide, specifically for behavioral health. Then we move to Commissioner Sullivan, who shared New York's comprehensive response system, available to all New Yorkers, regardless of availability to pay, through various initiatives, such as their Coordinated Care Service, Inc. initiative, the development of different crisis stabilization centers based on crisis level, and developing a crisis residential program and collaborating with diverse communities. I completely agree with Stephanie that despite the differences in state and local systems, we heard that a lot of the challenges were really very similar challenges. There's the issue of spreading the awareness of what is 988, what should people expect for 988, of providing a framework that can be standardized across different regions and communities, and particularly triaging to third-party callers decriminalizing mental health, and geolocations for the whole, so being fast in responding to these crises. We also heard a lot about the lack of trust in communities of color and the importance of maintaining equity and the need for data to further inform the conversation. I want to thank everyone for particularly giving such rich information. A recording of today's event, along with full bios and presentations, will be posted on this webpage in 7 to 10 days. We again thank our distinguished webinar participants, the working group that so much helped us in organizing these 2 webinars, and the National Academies of Medicine staff. Thank you all who have been viewing the live stream and sending in questions and comments, and we hope to hear from you soon. Thanks so much.